Picture a patient violently twisting under the sheets, aggressively scratching at their skin in the dead of night. This is the clinical presentation of sleep-related urticaria and pruritus, hives or intense itching that manifest or significantly worsen, specifically after the sun goes down. Recurrent awakenings relentlessly interrupt sleep continuity, presenting a severe risk to the patient's neurological recovery. This chart compares a healthy sleep cycle to an impaired one. Left, a normal hypnogram weaves down into restorative N3 deep sleep. Right, jagged spikes represent frequent itch-induced awakenings. These microarousals decimate the N3 stage, guaranteeing daytime fatigue despite 8 hours in bed. Because these episodes often resolve by morning, standard daytime dermatological assessments frequently miss the severity of the nocturnal events. The true pathology extends far beyond the visible rash. The condition actively dismantles the patient's critical sleep architecture. Nighttime itching is rarely a random, isolated flare-up of daytime allergies or localized dermatitis. It is a predictable, actively mediated state governed by the body's internal circadian clock. This diagram illustrates exactly where 3 distinct medical disciplines converge to explain this condition: dermatology, immunology, and sleep medicine. To treat these patients effectively, we must map the exact physiological pathways that activate the moment they try to rest. Normal sleep initiates a series of baseline physiological changes in the skin. First, peripheral blood flow naturally rises. This increased vascular activity elevates the skin's surface temperature during the early stages of the night. This cross-section shows the resulting physics of the skin barrier. As the temperature ticks upward, we see transepidermal water loss. Heat accelerates moisture evaporation, sending water particles escaping outward and physically weakening the epidermal shield. As the barrier weakens, the body's first major endocrine shift occurs. Cortisol, our natural anti-inflammatory hormone, drops precipitously at night. Exactly as anti-inflammatory protection falls, the opposing immune response surges upward. The circadian rhythm dictates a natural increase in histamine release. The convergence of elevated heat, accelerated water loss, depleted cortisol, and high histamine creates a highly sensitized epidermal environment. This specific neuroendocrine cocktail actively primes the skin for severe inflammation, timed perfectly to the hours a patient needs to sleep. Deep inside the dermal layer, we can trace the precise cellular triggers of this immune response. This is mast cell degranulation. The spherical cell bursts, rapidly scattering inflammatory mediators directly into the surrounding tissue. The newly released histamine and cytokines aggressively hunt down and bind to local receptors. Watch this vector diagram as the histamine molecules lock into their receptors. This binding forces the adjacent capillary tubes to swell and widen, increasing vascular permeability through vasodilation. The localized swelling physically presses against and sensitizes the peripheral nerve endings embedded in the skin, firing pulsing signals upward. Those signals travel straight to the central nervous system, where sensory amplification takes over. At night, external environmental distractions drop to zero. Without competing stimuli, the brain hyperfocuses on these internal nerve signals. The biological alarm bells ring louder in the dermal tissue, and the isolated, sleeping brain actively amplifies their volume. Amplified sensory input demands a mechanical response. The patient begins to scratch aggressively. This inflicts immediate physical trauma on a skin barrier already compromised by nocturnal water loss. We can map the resulting inflammatory feedback loop here. The itch prompts mechanical scratching. The scratching causes barrier damage. That skin damage triggers a fresh wave of cytokine and histamine release, which immediately generates more itch. This physiological panic response easily overrides any attempt by the brain to maintain or re-enter the deeper stages of sleep. What begins as a subtle circadian chemical shift escalates into a self-sustaining physical trauma loop, guaranteeing total sleep disruption. Treating nocturnal itching exclusively as a localized dermatological or allergic problem will often result in clinical failure. We must evaluate systemic pathologies, focusing heavily on the organs responsible for toxin clearance. This diagnostic tree highlights the underlying systemic diseases most likely to present with sleep-related itching: chronic kidney disease, liver disease, and thyroid dysfunction. When metabolic clearance fails in these specific organs, circulating toxins build up in the bloodstream, eventually aggregating around and triggering widespread peripheral nerve sensitization. It is critical to differentiate the specific nocturnal restlessness caused by pruritus from other sleep disorders like obstructive sleep apnea. The diagnostic workup must also rule out restless leg syndrome and parasomnias, as not all nighttime movement stems from itching. Diagnosing isolated nocturnal pruritus requires the clinician to look past the surface of the epidermis and evaluate the integrity of the body's entire systemic clearance network. The therapeutic goal is to halt the physiological cascade to protect the continuity of deep sleep. This roadmap shows how we intercept the process. Targeted antihistamines cap and neutralize the histamine receptor signal. Next, heavy moisturizers create a solid shield layer, restoring barrier function and blocking transepidermal water loss. Finally, strict environmental controls force expanded capillaries to shrink back to normal size. Chronic or systemic cases will require advanced considerations. This means adjusting medications for underlying liver or kidney disease, or deploying specialized treatments for central neuropathic itch. Successful clinical intervention requires strategically stacking these therapies to systematically dismantle each isolated layer of the nocturnal itch mechanism. Returning to our hypnogram, we see the immediate impact of this targeted blockade. The highly fragmented spikes vanish, and the pattern smooths out into a healthy, undulating curve that rests heavily in the N3 deep sleep zone. Nighttime itching is an actively mediated, sleep-disrupting condition with a physiological profile distinct from standard daytime rashes. Identifying the exact neuroimmunocircadian trigger is the only way forward from managing acute symptoms to achieving chronic resolution. By treating this physiological intersection, clinicians rebuild the foundational architecture of sleep, restoring the patient's systemic health and daytime vitality.